Okay, we'll go ahead and get started this evening. Thank you again for joining us this evening for our continuing lecture series from the Texas Physicians for Social Responsibility, our series on climate change and mental health. This series is brought to you by the Southwest Center on Occupational and Environmental Health, which is a NIOSH education and research center at the University of Texas Health School of Public Health. I'm going to be your host for the evening. I'm filling in for Becky Barnhart, who's not available this evening, and my name is Dr. Brett Perkison. I'm a family medicine as well as an occupational and environmental medicine physician. I'm a faculty member at the Texas School of Public Health here in Houston and a board member of the Texas Physicians for Social Responsibility. I'm very pleased to be able to announce our speaker for this evening. Dr. Jessica Isom, MD, MPH, is a board certified community psychiatrist and clinical instructor in the Yale Department of Psychiatry, where she serves as the co-director of the Social Justice and Health Equity Curriculum. She is also a practicing community psychiatrist in Boston at the Codman Square Health Center. Dr. Isom received her MD from the University of North Carolina at Chapel Hill, also received her MPH with a focus on public health leadership. We are very pleased to introduce her tonight to present on the topic climate change and mental health, what to know and what to do about it. A few housekeeping items before we begin. I'd ask you all to please remember to mute your devices, and please put any questions you have in the chat, which I will be monitoring, and we will get to them at the end of the presentation. And as time permits, we'll also open it up to the floor for questions from the audience. With no further ado, I will turn the presentation over to Dr. Isom. Welcome.
Thank you. I appreciate it. I'm going to share my screen. Just a moment. All right. So my goal tonight is to present for about 40 to 45 minutes, leaving space at the end for any questions or answers or comments. So I'll do that, and I'll pace myself accordingly to make sure the space is there. And what I'd like to first mention to you all is that I don't have any disclosures that would affect this presentation this evening. And what I'm going to take us through is an exploration of the following. I'm going to start with some background and historical context, just recognizing the audience likely has a number of, has a variety of familiarity with the topic. And then we'll dive into specifically talking about, in part two, links between climate change and mental health. I'll then talk about some focus areas that we can consider as clinicians that would represent our application of an equity lens to this conversation. And then I'll distill some of this into some action steps that would be in support of mental health equity before, during, and after climate-related disasters. And then I'll open the floor for a Q&A. Just to level set and get us started, climate change is a long-term change in the average weather patterns that we're experiencing across the globe, and it's happening to local, regional, and global climates. It's a current concern now and also a future concern, and the positive there is that we can actually mobilize ourselves to respond to both the current and also the future concerns that are present. And it's important to note that there are a number of impacts on health beyond a focus just on mental health, and I'll review some of those here just to kind of level set us. And this is an image that comes from the Centers for Disease Control, the CDC, and it describes at the center of the image some of what we hear a lot in these discussions, which are concerns about rising temperatures in the environment, concerns about having more extreme weather events, rising sea levels, and also increased CO2 levels in the atmosphere. And then connected to that are some of the challenges that we see across the board, with some overlap with mental health in some of these categories and others being more distinct. So connected to air pollution, challenges related to asthma and cardiovascular disease, or for example, our experience of having impacts on the quality of our water can expose us to more threats from an infectious disease perspective. We also have to deal with how evidence of environmental degradation now and in the future will affect populations, causing forced migrations, increasing the likelihood of having conflict amongst amongst population groups or between them, and that also having a mental health impact. And then other considerations include extreme heat and how that can produce a higher vulnerability to or risk of heat-related illnesses. And finally, another example from this graphic would be how severe weather itself can cause injuries, fatalities, and also has some mental health impacts. And entering into this conversation for me has been a really fabulous journey supported by an experience that has allowed me to apply a different kind of lens to this conversation that's connected to my larger work in the healthcare space around health equity. And the question that was answered for me throughout this experience was, what aspect of this discussion are we often pushing to the margins? So 2 years ago, I participated in this Climate and Health Equity Fellowship, personally sponsored by the National Medical Association as one of their group members. And for a year, was supported in developing an understanding foundationally of climate and its connection to health equity, and supported in thinking about this discussion as a psychiatrist through that lens. So I wanted to give them an acknowledgement and also encourage anyone present who is eligible to check out this fellowship opportunity because it was really helpful in forming my understanding of an approach to this particular discussion. So thank you to those who are in support of the Medical Society Consortium. So what are some of the considerations with that said and how we might think about foregrounding climate change and health equity? Well, with any conversation, there's often going to be a discussion in there around how inequality is going to show up. And when we're thinking about inequalities, the approach that we should take to that discussion has to be one that is inclusive of equity. And it really is about responding to unequal burdens, vulnerabilities faced by particular communities, some overlapping, some distinct, and also thinking specifically about how we imagine protecting ourselves from ongoing climate changes and future risk, and how we make sure that all people are able to benefit from those efforts. And climate equity is really a part of the larger discussion of environmental justice, which is one component of overall efforts to have justice be a part of how we have all conversations connected to health. And that allows us to, as more folks are coming along, really, again, develop frameworks that help us see or reveal distinct or overlapping vulnerabilities and then respond to them accordingly. And it's really lovely to see over the past 5 to 10 years, there being more of a focus on equity that helps us have, again, more of an understanding of unique and overlapping concerns and then be responsive to them adequately. Another thing I want to foreground here is how we think about mental health, and I really appreciate this model from a scholar, Keyes, which describes where we all fit into the conversation around mental health. And I'll say I am a psychiatrist. I do work clinically with patients in the Dorchester community of Boston. Many of my patients are represented as having as some kind of mental illness on this graphic. That would be the horizontal axis. So some of them are having minimal symptoms, some are having maximal symptoms. And at the same time, they still have a capacity to flourish or languish. And then in general, even folks without diagnosable mental health conditions can still end up at the top or bottom of this graphic. There can be times where they are languishing in response to maybe acute stressors or chronic stressors, and at other times they may be flourishing. And the conversation becomes, for us all, what are those contributions that can support flourishing? What are the ones that support languishing? And how can we think about those in this conversation, not just during and after climate-related disasters, but also before? And we'll talk a lot about that. And mapped onto this graphic, it's important to consider what groups have a greater vulnerability to languishing before, during, and after climate-related events. And those are the same groups that are experiencing social determinants of health broadly and social determinants of mental health specifically, and that are not ideal. So you have children, you have the elderly, you have folks who have low access to wealth, also known as low-income populations. And then you have folks that have a diagnosed mental illness. And of that group, there is a carve-out for those that have serious or severe mental illness. And you might consider those are people I often see as a psychiatrist. However, many are also managed in primary care settings that carry diagnoses of schizophrenia, bipolar disorder, and other things. In addition to that, you have communities of color, BIPOC communities, or as I reference them, racially and ethnically minoritized populations, who, because of a legacy of structural racism and discrimination in our country, represent a group with greater vulnerability as well. And I'll also point out that there are intersections represented here. So just thinking about these not as groups in isolation with one demographic characteristic, but the overlap between these groups is important as well for the discussion. And just to offer some data to reveal how these groups show up in the conversation around incidence or prevalence of mental health conditions, but also access to care. On the left, there is a racialization of and class experience of having chronic mental health conditions. So lower socioeconomic status or less access to wealth as well as a racially and ethnically minoritized status or identity is associated with higher rates of chronic mental health conditions, and importantly, also poor overall mental health outcomes, often connected to two things: a lack of access and also poor quality care being received. And then as far as the association between access to wealth, those that live below the federal poverty line are more likely to be disproportionately racially and ethnically minoritized, and also that's represented here in the data with a higher proportion there. You also see amongst low-income adults or adults that have low access to wealth, that they are twice as likely to have certain conditions such as depression versus those who do not have that positioning as far as class. And a lot of this is connected to stress from financial instability. And I'll say as a psychiatrist working with my patient population, so much of what we are grappling with often are social determinants and how that affects their overall mental health and well-being, distinct from just having a specific condition. And that point is so important for this conversation because it helps us to consider what some of the solutions might be. There's also a racialization in access to mental health care with less access, for example, here for Black adults with mental illness versus those of the general population. And then as far as the incidence of symptoms of anxiety or depression or depressive disorder, there's differences there that are racialized as well, related to exposures, not necessarily anything else than that. Finally, as far as children, we know there's a vulnerability in that instance, and this data point here is from post-Katrina study that found that up to a third of children, or almost a third of children, develop some symptoms of PTSD, anxiety, or depression. And we also know from our colleagues in the pediatric space that there are a lot of considerations here even preceding. So mothers who've been exposed, for example, to environmental, like toxic aspects of the environment, in that setting, brain development can be disrupted. In addition to that, we also know that parental stress itself can have a negative impact on children and their development when it's not managed adequately with resources or other forms of support. As far as the elderly, they are part of the conversation as well. One way to think about their risk is around their exposure to heat, extreme heat conditions. And if you think about the intersections, to be a low wealth, racially and ethnically minoritized elderly person, and I see patients, for example, that meet these different intersections in my patient population, and maybe add on that they have a severe mental illness such as bipolar disorder or schizophrenia. They are showing up in the data connected to mortality and also other less extreme consequences from their exposure to extreme heat as well. So they have to be a part of the conversation. And of course, as mentioned here, those that have severe mental illness are 2.5 times more likely to die during heat waves as well. There's some contribution there from just being prescribed medication. Lots of what we offer for common mental health conditions, those medications can affect the ability for the hypothalamus to regulate temperature. So there should be guidance across the board for anyone taking those to be very careful in regular heat conditions and even more careful in extreme heat. In addition to that, however, there's a social decline that folks with serious mental illness experience, often in addition to that, having low access to wealth and not having many of their basic needs being met. So I've had patients choosing between or having to live with a fan in extreme heat conditions while also managing a chronic health condition. And it's a kind of a perfect recipe for a disaster in that sense, as far as their vulnerability to these extreme heat related consequences. So as far as key takeaways for this portion, we have to recognize that there are social, political, and economic contributions to populations being pushed to the margins, and they exist also with mental health conditions as well, and that can compound their risk before, during, and after climate-related events for some of those negative outcomes. It's important to think about who has access to adequate resources, such as material resources, but also social support, and access to mental health care when symptoms are mild, moderate, or even severe. And that access can be different in ways that are detrimental, and that can create the cycle of vulnerability and worsening health outcomes over time. And when thinking about our approaches to this conversation before, during, and after, it's important to foreground health equity so that we're adequately viewing some of the vulnerabilities there and also some of the strengths, and using that to inform our decision making. So then the question becomes, what are the links between climate change and mental health? And I'll go through a graphic that will outline that for us. And this graphic is from the World Health Organization, and it describes the linkages between climate change related hazards and environmental threats, and how that has a direct impact on mental health. And it also talks about these specific exposure pathways that we can think about as well, that have an impact on mental health as well. So some examples of this would be on the left: extreme heat, floods, storms, sea level rise, drought, and wildfire. And I'll call out at the bottom left, as far as global environmental threats, that repeated exposure to climate-related disasters themselves that can create or directly negatively impact mental health. So what are some exposure pathways that we might think about? There's the environmental aspect, for example, of air pollution. There's socioeconomic considerations, for example, of losing one's livelihood. So maybe someone's working and living off of the land experiences some climate-related disaster. They're no longer able to make use of that property for their livelihood. Something else to consider: loss of autonomy and control. Right now in Boston, there is a really significant or a long-standing issue with public transportation in the form of our railway, our T. And a lot of people are experiencing loss of autonomy and control just around getting around. And with those differences and the ability to use the what would be called the subway system elsewhere, they're spending more time outside, actually exposed to the weather conditions. So you'll hear people talking about, in a milder sense, being rained on or being exposed to the high heat temperatures differently than usual, connected to a lack of transportation being adequate. And one might imagine how other disruptions that show up over time can create this particular experience and be connected to increased risk of just general distress psychologically and or the development of common mental health conditions. So some examples in addition to that might be specifically related to loss of personally important places, that someone just experiences a loss that threatens their home environment, the way they operate in their daily life, and that can cause emotional distress or disorientation. Someone might lose access to some part of how they operate, such as a part of their community no longer being available due to a flood that happened recently, and how that can have a detrimental effect. People being able to go outside, specifically children, can be impacted by air pollution, and that can cause disruptions, particularly right now in the summer months. And then we talked a bit already about loss of autonomy and control and how that can show up. All the way to the right are some examples of possible mental health and psychosocial outcomes, and I'll go through some of those with you all now. So as far as stress reactions and related physical health problems, having the experience of climate-related hazard or disaster itself can produce emotional suffering or psychological distress. But I do want to call out that that exposure alone doesn't predict a negative mental health outcome long-term. When people are able to restore a sense of safety, stability, have the resources that they need, including access to coping support, a lot of folks are resilient and able to bounce back. Something else to call out is the increased risk of suicidal behavior. There's some data suggesting that the risk of suicide can be higher for folks experiencing repeated adversity related to severe hazards or climate-related disasters, which makes sense. There's also some data suggesting in different countries that higher ambient temperatures have contributed to a higher risk or increased suicide rates. As far as strained social relationships, especially now during the summer, in particular here, and specifically in my community that I work in, which is an urban heat island, there's a lot there around how the higher ambient heat temperatures can contribute to an effect on interpersonal relationships, and specifically can contribute to higher rates of intimate partner violence. In addition to that, other considerations might be, were there to be an event, how might that disrupt family connections or relationships with institutions, such as children being pushed out of school, and what impact can that have on the family and the children specifically. We also know that mental health conditions themselves can be a product of being exposed to these events as well, or disasters, and that includes things like anxiety and depression, which are quite common, and sometimes stress-related conditions as well. And that can be acute, transient, for a few months, acute stress reaction, or more long-term in the form of PTSD. And we also hear and see a lot of helplessness, fear, and grief being experienced as well in connection to these events, both current day anxieties or preoccupations, but also about the future. So as far as generational exposures to this conversation and the events, for younger generations who will spend much more of their lives suffering the consequences, there's a lot of conversation there, and the development even also of new diagnostic labels such as eco-anxiety or eco-grief. So some key takeaways from this is that there's a lot out there that talks about the linkages. There's much more to be done with that evidence base or research base. So there still are ongoing things that we'll discover over time as mental health is being centered more than before in the discussion. But we do know that these hazards and threats can directly impact mental health, and indirectly through those exposure pathways discussed can have an impact as well. So the question now becomes, well, what are some of the areas of inequity that we as clinicians should understand and be able to respond to? And I've selected focus areas that are directly relevant to all across the spectrum of before, during, and after. And I just had clinic today, and just can imagine, I was just thinking as I was working with my patients who are actively struggling, many of them with the social determinants of health and mental health, just to make it through day by day, while also managing diagnosed conditions such as anxiety, depression, PTSD. How would they experience at their intersections these aspects of or these representations of how social inequalities can affect an experience of a climate-related disaster? So we'll start with the disproportionate impact itself on low-income and minoritized communities. We'll then I'll offer some examples of how the evacuation as an immediate response to a pending disaster can present challenges for folks that don't have access to enough resources or supports. I'll offer an example of long-term displacement and housing insecurity and how that can be connected to mental health outcomes. We'll then talk about aid, both its inequitable distribution and those effects, but also the application process itself and how cumbersome that can be. And finally, we'll talk about the connection between jobs, security, and also economic stability as well, and its connection to mental health. So the first example is just really thinking about how the groups that are most vulnerable, most exposed, partially represented here as those who have low access to wealth and who represent minoritized groups, they are often left hanging in lots of situations when we're trying to recover from a climate-related event. So here's a news article talking about the time it takes to get power restored, but also the vulnerability to loss of power and how that is both raced and classed. So it says it takes a toll. U.S. low-income and communities of color endure longer power outages. So in our relationship with patients, families, and communities, as we're recognizing a predictable climate-related disaster, how might we have conversations to prepare them for the psychological distress, among other consequences, of having to be more at risk of loss of power and also to experience a longer delay in having it restored? Another example of the evacuation and how that can be challenging, and also how much folks are able to meet the expectations of an immediate response. Here represented by an individual who was in a community hit by Hurricane Ian. And here, some of the folks could not leave. So they were left, kind of fending for themselves with limited resources in this environment. So how might we have conversations with folks who can leave and have the resources to do so versus folks who might have to hunker down and stay? And how does that, and it does, but how might that represent a different kind of conversation than some that we traditionally have, which often include assumptions around access to resources and abilities to move? Another part of the conversation is around long-term displacement and housing insecurity. So folks are displaced across the board. Some are more vulnerable than others. And then there's the coming back. And so there's a loss in the coming back and what that represents. So having displacement without having adequate assistance can really disrupt community ties and also can lead to long-term consequences. So you might have groups, for example, who are on tribal lands or who are on unrecognized pieces or unrecognized communities that are less visible, who might become visible in the midst of a disaster related to climate change, and then are not able to access federal resources due to their invisibility or lack of recognition for being eligible. And also, how do they process the loss of land that for them might have a completely different meaning versus someone who just loses access to a neighborhood where there's some connection there, but not as deep or ancestral as a person represented in this article. And then to the right, there's another news story that talks about coming back after to a housing condition that's not safe or suitable for being able to live there, which can contribute to longer term displacements. There's also stories of folks who were displaced and can never come back due to a lack of resources. And then when they do come back or when they're dealing with that displacement, there are, of course, a lot of mental health challenges that can come along with that. And relatedly, there's also an inequity in distribution of aid. And here's an article from the New York Times talking about disaster aid and why it often favors white people. And the subtitle there is the federal government often gives less help to Black disaster survivors than their white neighbors. And it's talking about a policy shift to address that. And I'll talk about that a little bit more in the next slide. And this is connected to, again, a history of structural racism and discrimination that has affected housing. We have residential segregation, we have legacy of redlining, we have these things that have created these current conditions. And similar to how schools are more funded when they're in areas with a higher property value, and those areas are often racialized, here your property value determines how much you get as far as aid. So there's a representation here of two families. To the left, there's a person with home damage that received $17,000. To the right, a similar home damage, they received $7,000. So the ability to rebuild after disaster is, of course, going to have an effect on how folks experience a disaster during and after, as far as their mental health. And then a part of that, too, is what do you do when you're trying to access the aid that you might be eligible for? And there's been really, really complex application processes for some time. The positive here is that that's changing and shifting, somewhat disappointing in that a lot of this has happened in the past year or two. So the recent report from FEMA around how they are infusing equity into their disaster recovery and aid processes came out in 2023. And here are some news articles that came out in 2024, kind of talking about that. So there's difficulty with technology access, for example, or specifically even access to Wi-Fi to get to the application. There's difficulty in getting real-time, up-to-date information to know where to even go or what to do. And then there's a pretty high chance that you'll be rejected the first time. So this article on the right is talking about one program rejected 46% of those who've sought help since 2002. And then when they're approved, they're not approved for very much. So there are efforts to address this, to make the process itself more equitable, language considerations as far as access, just having a lot of information out there available to folks that is easily findable, and then really just making sure that how they create these algorithms that support their totaling of the aid that's deserved, making sure that has an equity lens applied to it as well. And then finally, one consideration might be, if there was some kind of event or disaster, what does that require from us? Let's say it affects our home. So if my home was flooded or experienced a fire or really any adversity, as a physician in my health center, I would have a lot of flexibility to probably still work. I could do remote work. I could take time off if I needed to, use my vacation time. I would have some disposable income to cover me if I had to step away from my job for a period of time. And many people I work with, and even many people I know, would not be able to do that. So folks that have low access to wealth are less able to be flexible in response to a disaster, and that affects their ability to recover. So they might have to take away time and focus on their immediate needs, and then not have access to funds to even to go back or plan for plan for an extended level of displacement over a period of time. So a lot of folks are dealing with, again, those social determinants of health and mental health before, during, and after. So we do know, as key takeaways, that societal inequalities have a negative impact across the board. And we have to keep that in mind when we're thinking about what can we do now, before, what can we do during, and then also what can we do after. So then the question becomes, and this is our final question, what can we reflect on? What kind of action steps might be considered to support our patients, our families, and communities? And the goal here is to have this conversation rooted in our understanding of and acceptance of that when we're having this mental health and climate change conversation, one, we're centering equity in it, and two, we're recognizing it goes beyond just having a mental health condition. And what I'm showing here in the center is from a text on the social determinants of mental health. And you can see here, there's a representation of exposures to the impacts of global climate change at the top right. And there are so many other factors here listed as well. And you've heard those reflected in some of my comments already. So we have to have a conversation about the SDOH and the SDOMH in order to really shape how we think about, imagine the kind of solutions that would be helpful. And we'll talk on the left in these suggestions about some representations of building community resilience, often around adaptation to the present risk and the future risk. So things such as improving social relationships, increasing how much we put things together and integrate them, ensuring that we are communicating with folks that need the information, what their risk actually is. For example, communicating with patients who are on pharmacotherapy for common mental health conditions, that living in an urban heat island puts you more at risk this spring and this summer and maybe parts of fall for having a heat-related illness, so protect yourself. It's also important that we are boosting up the physical and mental health of these populations now so that they can be more resilient in the future when these do occur, and that we're really leaning into what are the healthy aspects of these communities and how can those be leveraged as well. So I'll talk about some adaptation strategies and some mitigation strategies, and then I'll open the floor to you all. So mitigation strategies are intended to reduce or prevent the release of gases and greenhouse gases into the atmosphere to slow down the process of climate change. And for us as healthcare professionals, primarily here, it really is around how we might, for example, reduce our carbon footprint and how we operate, and also support policy-related discussions around what can be done to reduce overall emissions. And one focus area for us could be promoting sustainable healthcare practices. So how do we think about use of energy in our facilities? How do we think about waste? And how might we use this knowledge to advocate for sustainable practices within the healthcare spaces that we're in? So one approach to this as an organization might be to form a green team and do that or have that discussion informed by whatever resources are available or collaboration with folks who have some expertise. And that could lead to discussions around specific ways that are actually achievable for reducing the carbon footprint of your organization. One really interesting thing I came across was that this conversation around telehealth connected to the COVID-19 pandemic really is also a representation of reducing our carbon footprint. So shifting more to web-based approaches to supporting folks that have certain conditions that have an evidence base for telehealth being pretty powerful is something we should be paying attention to. And any comment I offer for me is offered through an equity lens. So I'll also transparently say that in shifting to web-based platforms or interventions, we have to think about equity as far as technology and access to related resources. So if we were to move towards this, or as we're moving towards it being flexible. So for myself, I have patients I see through telephone and video, and a lot of my patients make use of telephone services across the board. That might not be applicable to all disciplines, but is a representation of kind of tailoring access to care. In addition to that, if we were going to shift more to web-based offerings for sleep or insomnia or depression or anxiety, we should still be offering face-to-face opportunities to folks who may not have access to technology. So I wanted to show this graphic on the right and then some suggestions from this resource. On the right, it's a representation of how we might think about sustainability and mental health care connected to how we contribute to carbon emissions. There's here in the center, mental health, broadly defined. I'm not sure what it quite means there, because it could include psychiatrists. It could even include primary care, who do offer most of the mental health care in this country. But here there's some representation of how we are spread across the board in these different categories. And a lot of what comes from our contributions are related to travel, so electricity and also gas, as well as included there, and patient travel and guests that come along with them. At the top, you see general practitioners, broadly defined. I believe that to be primary care, and there's differences in contributions there. To the left, what we might do based on the organization we're working within or the specific group is consider how might we draw upon this information to pivot a bit to reduce our carbon footprint. So one can be the suggestion I already talked about as far as using web-based approaches, again, that are evidence-based. So if we were to shift to evidence-based interventions like CBT for depression, anxiety, and insomnia, we would cut our emissions or cut our footprint down to a fifth of what it would be if we did face-to-face treatments. We might also consider, I have lots of patients who make use in Boston of supported transportation. Are those vehicles ones that are paying attention to their contributions or not? Or how might we group folks to go from appointment to appointment to reduce the footprint there? The computers in our offices, we could just install a piece of technology that shuts them down when we're not using them overnight. And also another interesting consideration, as a person who prescribes medication to folks that have some vulnerability to overdose, I've noticed this increase in use of or increase in forceful suggestions of 90-day supplies. And I've had lots of thoughts about it. And it was interesting to think about it through this lens, that having a larger medication supply or just a medical supply in general would reduce carbon footprints by reducing visits to the pharmacy. So I don't know for sure if that's the primary or even partial rationale for pharmacies or for insurers to strongly recommend in pharmacies to participate. But it's an interesting idea to think about how many different ways we can look at that policy, and some of those ways reveal actual benefits to that strong push towards 90-day supplies, at least where I work. Another consideration for mitigation strategy can be education and advocacy. So talking to the public, talking to policymakers, and also other healthcare professionals, not only having those conversations, but joining them as far as advocacy efforts. And I think here, the more I look in my local area, the more I see these are already happening, often from community or grassroots organizers. And it's less about us as healthcare professionals coming in and taking over and having power over relationships, and more so about being curious about what's out there, partnering, sharing power, and kind of co-creating sessions for both ourselves as healthcare professionals and also for the public and the community. Green prescribing is another focus area that we might consider. This is encouraging lifestyle changes, of course, recognizing not everyone can do these things or has the resources to, but in the ways that we can, encouraging things that would help support like mitigation of climate change over time. And I represent here an example of a program that exists and that my clinic is a part of, that again doesn't explicitly mention this as a mitigation strategy for climate change, but it is. So this is a .rx connection. We can refer our patients there, and it's a collaboration between Blue Cross Blue Shield Massachusetts, our health center, and some area resources, including Health RX, which is a gym that you can give a prescription to for 3 months for patients to make use of, and also the Daily Table, which offers like farm to table wholesome foods at a discounted price to folks who are eligible for that particular resource. And there's also a connection to the YMCA as well in their programming. So how might some of these recommendations in alignment with what we want to promote as far as overall mental health and well-being, or health and well-being, actually represent green prescribing, and how can we focus on those would be a conversation. And I'll close out with some adaptation strategy suggestions, and these are around how we might lessen the impacts of what's already happening or what will happen. And it's really important for this conversation to be focused on building resilience or tapping into it, and then just preparing communities to face the effects of what will happen, such as just more frequent extreme weather events. And one example of this can be for us in our approach to adaptation, making sure that we have a sense of what structures are at play here. And I've woven that throughout tonight's discussion because there are things that are contributing to vulnerability to risk that are outside of a person's individual choices and behaviors. We also have to think about how we make sure that our interventions are culturally sensitive, that they are applicable to the populations that we're interfacing with, and not a one-size-fits-all approach. And I'll offer an example of that in just a moment. But for ourselves, should we possess this already, spreading the wealth and sharing it with others in our profession is very important. And then also going beyond that to have conversations with others informed by that in the community. And sometimes it's not us. Sometimes it's inviting community members themselves, again, from these grassroots organizations, to tell us what we need to know that would increase our level of structural competency and increase our level of cultural sensitivity and how we're thinking about some of the strategies that we come up with. It's also important, again, to emphasize that around adaptation, if we're thinking about relationships with the community, that those relationships should be as non-hierarchical as possible. Again, a sharing power with, co-creating with, co-developing with, as opposed to a power over paternalistic approach to those relationships. And the reason for that's pretty practical. There's a bidirectional learning that can happen that can help us to be more effective and help the community to be more resilient. So one example of community members joining these conversations here is the Boston Climate Action Network. This is organized by Boston residents, and they collaborate with other social justice groups here. And they have made sure that they're a part of the conversation that's happening here around becoming climate ready as a city of Boston. So we may need to establish, though in lots of ways we could just join forums that currently exist, but maybe create them to have, again, that ongoing conversation that helps us to be as responsive as possible before, during, and after a disaster. Something else to consider is just making sure that we have a sense of what kind of recovery policies or plans are in place. And some of us might be positioned in areas that have a lot more information than others available for review, or in organizations that have information or don't. So there might be just some question asking or curiosity-based approach to this first. But advocating for equity as far as those disaster recovery policies, and then ensuring that the plans that we have in place are equity minded or inclusive is really important. And that could just be joining the conversation with policymakers or community organizations and kind of offering what we can, but also learning from past failures with recovery plans that can give us a sense of what we should advocate for in the future. Something else to consider too is just getting a sense of what is the vulnerability of your particular organization or your the place that you work in the community there. And that can help you determine what to focus on as far as your approach at whatever level, whether it be you with an individual patient or family, or you at a higher level in the organization coming up with some kind of plan, for example, with a green team. So there are some places that have a lot of information out there available that's very specific, and unfortunately able to offer that because I live in Boston and they've invested in that here. However, it might take more work in other places to find the information. So ideally, you would find the information available from climate health experts that details this for you and kind of make use of that. And then that can help you determine what kind of conversations you should be having and kind of plans that you should be creating. So for example, I work in Dorchester, which is a coastal part of the state. And here you can see represented on the left from a Boston Ready report. They've selected these 9 communities as a focus area, and Dorchester is one of them, Dorchester Bay specifically, and they're majority coastal. There's another community that's more interior, but they're mostly coastal. And they're worried here about the flood risk with that positioning of those communities. And they're thinking through proactively, okay, well, what do we need to do to prepare for that inevitable risk? And one of the things that's really important for us here is that we do have the information and still need to mobilize to act more and more around, translating this to those that we're working with. So while I personally have a lot of conversations with my patients around heat exposures and extreme heat conditions, for example, there are less conversations around the flood risk. And that just represents an omission that often is rooted in not having access to or seeking out this information, but also it not just being a habit that's been formed over time. So as we're counseling folks and working with our patients, it's important to develop these new habits of having these kind of discussions and then revealing to folks, one, that they are at risk in this way, and two, starting a conversation around how they might prepare for the inevitable and to be as resilient as possible. And this Climate Ready report for Dorchester has some recommendations there around what could be done. And they're prioritizing different parts of it and approaching it in a piecemeal way. There's grants being allocated to do some of this work in different towns. And again, this is a representation of this specific approach, which may not be the same experience elsewhere in the country. And almost finally, the last suggestion would be is that we're thinking about mental health support programs across the board. So having access to mental health support right now before is important to be as healthy or well as possible and increase the chances of being resilient in the face of a disaster or an event. But also just being ready to go should an event or when an event or disaster occurs is really important. So having partnerships is key. Knowing, for example, what are the assets in your area that could represent a potential partnership, which might be things such as churches, for example, or other faith-based organizations. It might be places where people just automatically collect, like the YMCA or the library. Those kind of relationships can help, or pre-existing relationships can help you to be mobilized when you need to offer the kind of support folks will need during and after the disaster or event. And one example of this is the All Healers Mental Health Alliance, a really amazing group. The current organizational leader for this is Dr. Anel Prim, who I have a personal relationship with and who's just a really great example of mobilizing to act after and then continuing the effort along from there. So they organized after Hurricane Katrina, and they've kept this going. And their approach is to be available to folks during and after a disaster, and specifically racially and ethnically minoritized folks who survived a disaster. And they offer them culturally competent mental health care and responses. And I've included here on the right an example of one of their resources, which is a grab and go kit, which is a way of, one, starting the conversation, offering some practical suggestions, but also encouraging folks to check out the website for more information to increase their knowledge around what their unique risk might be, but also what they can do to be more resilient in the face of that. So key takeaways here, just as far as what we can contribute to this specifically equitable disaster recovery, before making sure that we have a clear sense of who's most vulnerable as far as who has access to financial resources. And that can be just supporting folks again and addressing those social determinants that are connected to, for example, wealth. So are folks able to buy their medications? Do they need support with that? Are they able to keep things on that should be on, such as like electricity or gas? Are they able to make it to the place they need to go? If not, can we connect them to community health workers or other resources to support them having that strong foundation before? And then also we could think about supporting investments in resilience building interventions to help folks adapt once these happen. That could be an organization investing in just having conversations and offering resources to patients and families in the community to know what is our specific risk, be it flood or extreme heat, and then what can we do. It's also important to create space and really just more threads or connections between what community members are already doing and have them tell us what they need, where we should be offering support after a crisis. And then finally, there's a really collectivist part to this conversation that's really important. It's a population health conversation. It's not just about these specific groups, but about how they contribute to the whole ecosystem that we exist within. And nowhere was that more evident, I think, recently than the COVID-19 pandemic, where a person being able to operate a bus or show up to a grocery store affected a bunch of people who have no connection to that particular individual, but do have a connection through interdependence on what they're contributing to society. So equity-driven decision-making will benefit all of us in our approach to this conversation. So I have here at the end some references for you all, and I'll close with a quote from Jerome Foster II, which just offers us that climate crisis and social injustice are inextricably linked. Thus, in these conversations, it's really important that we're having a conversation about equity and justice as well. So thank you, and I'll open the floor now for the Q&A.
Great. Thank you so much for a really comprehensive presentation on looking at a lot of different aspects of mental health. I will invite you all. Yes, thank you. A lot of applause, virtual applause going on. I'll invite you all to put questions in the chat that I'll monitor. And after we finish with the chat, if you prefer, we've got about 10 minutes that we may have time for some questions if you want to unmute. So I'll start off with Maria's question here. Is it feasible to plan medical offices that explicitly advocate for green, sustainable health together with green prescribing, starting with information, declarations, green entertainment in the waiting areas, are there pilot projects that also study the impact of the Green Doctor's Office in mental health of patients? Just pause right
Yeah.
there.
Yeah, that's a great question. And I don't know for sure. What I would say is I would think if starting from the foundation of building up an organization, that it would be possible if there was enough of an investment in this as an issue. And then two, I wonder with you if there are examples of how to integrate this, not just the prescribing part of this, but into the organization, such as how we construct our waiting rooms. So I'm not sure of specific examples, but I hope that were we to search, there'd be examples of that out there that we could reference. So it's a really good question.
Thank you. And she furthermore says, I assume that patients that have been impacted by climate change are relieved to hear from their doctors that this impact is real and that they're doing something to take this issue seriously. So just kind of confirming their concerns by showing that the doctors are interested in doing something about it. So real valid point.
Mm-hmm.
Yeah, so I will go ahead while people are still considering other questions. One of the things I always am interested in is how can we incorporate this into our clinical model so that when we're spending time talking to patients about some of these issues, we can actually show, if you're working for an organization, that you're able to bill for this counseling just like you would if you were counseling somebody about diabetes or something else. And do you have, so I had a question, do you have any suggestions for coding to be able to bill for counseling to patients regarding social determinants of health related to climate change and specifically for mental health related activities?
That's a good question. And I don't know. I don't know the answer to that. I think a lot of things I offer counseling for under the umbrella of social determinants of health broadly and mental health specifically. They're coded as Z codes, which are not reimbursed at this time. So, including, for example, counseling I offer patients around their exposures to racism and discrimination. It's just a Z code. So that could represent, and I think does represent, an advocacy opportunity in that sense, coupled with a whole host of other examples of how that counseling is not necessarily valued. So it's a really good question. And I wonder, and I'm not as connected to the organized medicine space as I used to be, but I do wonder if in their climate related discussions, they've talked about that as far as like policy resolutions or things like that. Because we need it for this and so many other things that are a part of what we do. And then I'll say, as far as where this could fit in as well, my mind automatically went to what members of the healthcare team could have this conversation or could ask questions, and where would it fit in? And I know every time that conversation comes up, it's always, we don't really have enough time to do this and fit this in, for example, with nurses or medical assistants. But there might be, in this like evidence-based or this value-based care shift that we're doing in our use of technology, there might be ways to ask these questions before patients come in or during or after visits using that. And that would remove a person, and with support, a lot of patients could be able to participate. So.
Yeah, no, that's great. And I think at the very least, even doing the Z code, at least it allows us from an epidemiological standpoint to measure the help to measure the impact when we looked at large groups of populations that we're providing this care.
Mm-hmm.
I'll also, Dr. Cantu had a raise your hand for a question if you'd like to unmute.
Yes, thank you so much. My name is Adelita Cantu, and I'm the chair of the Texas Physicians for Social Responsibility. And on behalf of the organization, I'd really like to thank you for the presentation this evening. As you were talking, the one thing that came to my mind is that many times we focus on the physical toll that climate change, the intense heat, the intense cold, because we had that cold snap in 2021 here in Texas that caused a lot of morbidity and mortality. But it just reminded me how all things are connected. So even that physical toll is going to take the mental health toll as well. And we need to bring that together in our discussions, in educating the community about, like intense heat, but also understanding that does take a mental health toll, and how they can become resilient in not only physically withstanding that, but also mentally. So I do thank you very much for this conversation and the space you gave it tonight.
Absolutely. And it's why I brought up that conversation around the tea here in Boston, which alone is increasing levels of irritability and anxiety and just general angst. And then to add on top of that, folks having to navigate extreme heat conditions, they may not even recognize that just being more irritable also is connected to just being in high heat. So I think it could both validate and normalize folks' experiences and help us offer counseling that could be really useful, such as shade, hydration, and just being really thoughtful about exposures to the heat.
Thank you. We had one more question in the chat. How does the public discussion and denial of the existence of climate change affect vulnerable populations in terms of being more educated and proactive? So if I guess paraphrasing that, in their mental health. So I guess if I'm interpreting the question right, it's how does the sort of the widespread maybe denial or refutation of it being caused by anthropomorphic causes of climate change, does that cause mental anxiety for people that are really experiencing it on a day-to-day basis?
I would imagine so. That's a part of how I would answer the question. And then I would also say, connected to the COVID-19 pandemic experience again, that there's something about our positioning as trusted members of the community that could help us poke through. Let's say we're working with a population that doesn't have access to the information that would be most useful and has disproportionate access to like climate deniers, that leveraging our relationship similar to the ways that we did around public health measures during the pandemic could be a really powerful way of poking through and giving people access to information. I'll also say, there's people are already functioning with a dual consciousness, that I have these experiences that are connected to, for example, structural determinants such as racism and discrimination that exists, and I know it's impacting me, and I interface with people all the time that don't believe it. So it's not like a novel positioning to be in where you're in this like two dual realities of, well, one being an alternate reality and the other being truthful. So people are used to that. So I think to a certain extent, there's going to be some familiarity with that. It may not be as detrimental as we might imagine. And even still, though, more so about access to information that's accurate. I do think we just have a really powerful positioning to be the people that offer that information, hopefully it being received with less skepticism. So I would definitely lean into that for ourselves around that same question.
That's a very good point. Yeah, good way to frame it, to think it's not unique. So I guess we have just 2 more minutes. There was just one more comment by Bethisha Presik. I am a chemist working as a certified industrial hygienist, so I more often do things in my personal life, such as giving a refillable cup for free for soda and let people be inside with AC and social interaction. Did you, Bethisha, you wanted to unmute or comment further on that? If you have any other comments? I think maybe she didn't have audio on there. So yeah, so it sounds like sometimes a lot of it comes down to personal changes that you can also have while you're doing professional changes. I just wanted to say sometimes each one can help. Yeah, so small things in life.
Yes.
Well, great. Well, thanks so much. It's been a great hour. We'll make sure that this presentation is available to members, and I think we could ask a lot of questions. Keep asking a lot of questions. So thanks again. It's nice to touch base with you. We appreciate it.
Thank you all, and have a good night.
Okay. Good night, everyone.